Moment here to get settled. But I want to give everyone, our speakers, a chance to update us completely. Got it? Okay, I think we're okay. So just a couple quick announcements. On the screen, you'll see the ID for this Grand Rounds. As I remind everyone, we're truly trying to give everyone credit for attending and excited to have our fellow speakers today. Today was a challenging day with the weather. I know a lot of people are home with children because schools were canceled. But we are going to have a good crowd in here. I know a lot of people are joining remotely as well. So please get your CME credit. Just a reminder that next week there will be no Grand Rounds. Instead, at this time, we will have a faculty meeting. And I encourage you to attend that. Also, before next Tuesday, I want to remind everyone, if you have not yet RSVP'd, please RSVP to join us at our yearly winter gathering social event. It's a beautiful time to get together, wear holiday clothes that you might have received as gifts, and be in fellowship with your colleagues, both the staff, the faculty and fellows, and your guests. It'll be at the Divinity School, beautiful room there. And so we'll send out a reminder, but please RSVP and bring someone special. The following week, we have some speakers. The following weeks, we have speakers from Indiana and Washington University, and then another fellow presentation in mid-February. So a great set lineup for future Grand Rounds. Here's our disclosure information. And with that, I'm going to ask Dr. Rosenfeld to come in and introduce our first speaker. And thanks to Dr. Rosenfeld for coming out on a snowy day and even in her retirement, doing everything to help mentor the next generation. Thank you, Lynn.
So this afternoon, it's my really great pleasure to introduce Kenny Mizue. Kenny began his medical training in Nigeria, where he received an MBBS from the University of Nigeria College of Medicine. He then went on to get a Master of Science in Public Health at Angela Rankin University in the UK. After coming to the United States, Kenny did an internal medicine residency at Einstein in Philadelphia and a nuclear cardiology fellowship at the Massachusetts General Hospital. He arrived at Yale in 2022 for general cardiology fellowship, and I'm really happy to say that I think despite his time in Boston, we've shifted his interest from imaging to electrophysiology. And in working with Kenny over the last year and a half, I've been especially impressed by his enthusiasm and his desire to understand the mechanisms for phenomena, observed phenomena. And I'm sure that these characteristics will make this debate with Giorgio especially interesting and provocative.
And I'm going to go ahead and introduce Giorgio now as well. So Giorgio Mottola graduated from the University of Genoa School of Medicine in 2013 and then spent several years at UC San Francisco in their Cardiovascular Research Institute, where he authored and co-authored a number of papers on vascular biology. He then came to Bridgeport Hospital for his internship and residency. And I was recently talking to Stu Zarich, chief of Bridgeport, about a different fellow who said to me, you know, this kid is a superstar. He's a lot like Giorgio. So I thought that was a nice compliment. So today we're going to be hearing from Giorgio and Kenny debating wearables and atrial fibrillation, yay or nay.
Good evening, everyone. My name is Kenny Mizue. I'm one of the General Cardiology Fellows. And
I'm Giorgio, also one of the Kenneth's colleagues.
Good. Our topic today is consumer wearables and screening for atrial fibrillation. Should we be doing it or should we not? And we have nothing to disclose. And this is the brief outline of our talk. So I'm going to start, we're going to have an introduction where we basically define the lay of the land, and we'll both do that before we go into the debate. So I'll start first by trying to talk about how, the usual paradigm we have for atrial fibrillation or clinical atrial fibrillation is that the patient has symptoms, chest pain, palpitations, they go to the ER or they go to a doctor's office, and then they're found to have a very fast heart rate and AFib is detected on an ECG. But now that we have some of these devices that can pick up signals, even when patients don't have symptoms, we have this new category of subclinical atrial fibrillation. And we will define, the definition is kind of varied, but the components are that there are minimal or no symptoms. It's picked up usually by some sort of implantable device or a wearable, and you haven't gotten a documentation on the 12-lead ECG. And studies have been kind of varied in how much stroke risk you have with subclinical atrial fibrillation, but it can vary from as much as 2 to 3 times, for people who don't have it, while clinical atrial fibrillation usually carries a 5-fold increased risk of stroke. The role of anticoagulation in subclinical atrial fibrillation is still uncertain, and we're going to delve a little bit into that in this talk. We think that subclinical atrial fibrillation is likely responsible for a lot of cryptogenic strokes. There's a lot of papers that have shown that patients are diagnosed with atrial fibrillation for the first time. 25% of patients are diagnosed for the first time after their first stroke. And the idea is if we can somehow address the parts of that iceberg that are underwater, maybe we could get some benefit. And the thing about atrial fibrillation is whether you believe in these 2 different schools of thought, whether it's just a marker for risk or whether it's actually, clinically related to the pathophysiology of how AFib actually happens or stroke actually happens. For example, when that left appendage is occluded and then stroke risk goes down. Whether you believe in any of those schools of thought, you find that the duration and burden of atrial fibrillation is still the most critical part when we're talking about subclinical atrial fibrillation. That's something that, was reflected in the new guidelines where, atrial fibrillation is no longer like a binary variable where you have it or you don't have it, but rather how much atrial fibrillation you have, as well as how much risk you have, is going to interact to determine how much benefit you get from anticoagulation. I'm going to hand it over to Giorgio now to continue.
Thanks, Kenneth. So to continue our introduction, I just want to emphasize that there are many different ways that we can potentially screen or monitor for AFib. The simplest way, perhaps, is to check a pulse, auscultate the heart, or even check an ECG during office visits. And that's generally what we refer to as opportunistic screening. And that's actually the only form of screening that is strongly recommended by the guidelines currently. Last iteration was just last November. There are other ways that we could potentially monitor for AFib that are maybe more intensive, more systematic, with different tools, including consumer wearables that we're going to talk about today. Although guidelines really don't give us a lot of advice about the use of these devices specifically and about a more intensive and systematic screening. And the wearable devices mostly rely on photoplethysmography that I'm going to show kind of how it works in a bit. So what do we define as consumer wearables? It is a little bit of a broad term, but really any device that is generally worn by the person using it and that can monitor biometric data in a quasi-continuously fashion. Even though these devices like the Cardia that I'm showing here is technically not worn on the patient, we still consider it a wearable for the sake of this discussion, given that it still allows the patient right at home to check an ECG whenever they want without any physician guidance. So wearables can monitor all sorts of things. Of course, we're going to focus more on the cardiac side of things, but in addition to heart rate and rhythm, they can also track activity, pulse ox, VO2 max, and other things. So I mentioned photoplethysmography, but how does that actually work? It's really important to understand because that's the basis of how most of the alerts for an irregular pulse are generated by these devices. So essentially, you have an LED on the back of the watch. In this case, I'm showing a finger, but it could be really anywhere on the skin. And the LED will shine a light, which generally is green. If you happen to want one of these devices yourself, you'll notice that the light that is generated by these devices is green. Some of it will get absorbed by the tissues. Some of it will be reflected back to the detector. And how much will be absorbed or reflected is a function of the microvasculature and how it changes in volume. And that's the name of plethysmography, because that's a variation of volume. And what that gives you is a waveform which a little bit like an A-line waveform that allows you to calculate the heart rate and as well also evaluate for irregularities in the heart rhythm. And green, interestingly enough, is almost universally used for this particular purpose, as it has the optimal penetrance of tissues without being too disturbed by ambient light, as opposed to blue and red light. So I'm going to hand it over to Kenny. He's going to present his side of the argument.
Thank you so much, Giorgio. So I'm going to be on the side of the debate where I think wearables are going to be helpful in screening for atrial fibrillation. So I'll start first by talking about the WHO criteria for screening modalities that were outlined by Wilson and Jungner about 60 years ago. So the first part of their proposed criteria are that you should have an important health problem, and atrial fibrillation is quite important, affecting at least 2 to 3% of the population. There should be a treatment for the condition. We do know that anticoagulation reduces the risk by 60%. And then facilities for diagnosis and treatment should be available. There should be a latent state of the disease. Now, this is that subclinical atrial fibrillation we're talking about that we're just beginning to discover, and that's probably going to be very important to address. And the test should be acceptable to the population. The natural history of the disease should be understood, and screening should be continuous. But then there are other parts of the WHO criteria that I think are up for debate. For example, the precondition should have a good test. And so I'm going to spend some time talking about why I think the current wearables have an acceptable level of accuracy. I'm also going to talk about this idea of who should we be screening. I think if you start screening 20-year-olds for atrial fibrillation wearables, you're probably not going to be doing a good thing. So who we should be screening is very important. And then, is it going to be cost effective? And so these are the 10 criteria for an acceptable screening modality. And so I'll start by talking about atrial fibrillation. Like I alluded earlier, atrial fibrillation is actually pretty common. Up to 10% of really old people. And, 85-year-olds in the past used to be, we didn't used to emphasize a lot of treatment for them. But now that we know that the life expectancy is rising, if 10% of patients have a very potent risk factor of stroke, I think we should be addressing it in that setting. We also talked about the fact that it increases the stroke risk by 5-fold, and 25% of patients who are monitored after their first stroke actually get diagnosed with atrial fibrillation for the first time. Another thing about atrial fibrillation that I think is very interesting is when you think about a stroke, the treatment for a stroke when you don't see any other cause is usually antiplatelet therapy. But that doesn't really work if atrial fibrillation is what's causing the stroke. It only reduces stroke burden by 20%, while anticoagulation reduces by 60%. And that's why trying to figure out if they have atrial fibrillation setting of a stroke is important. And I did come across this study from Hanger, and it's a little bit old, but they did a survey of patients who had strokes, and they actually thought that having a stroke was actually worse fate than death. And so I think this is why atrial fibrillation is a very important thing to address. So the first question I want to address is, do wearables actually detect atrial fibrillation? And I'm not going to bore you with a lot of the studies that have been done on this, but I would point that a lot of the data is from small studies. So all those dots in the ROC curve, they are just the small studies. And then there are 2 large population studies, which I'll go through in a little bit of detail. But again, the meta-analysis of some of these studies have shown pretty impressive sensitivities and specificities for these devices. I know there's still limitations for these devices in terms of the fact that they could pick up arrhythmias and that are not AFib and call it AFib. And also the idea that, we're hoping to apply these devices to an elderly population that might not be digitally literate. I also want to point out that, there's this issue of whether they detect people who have darker skin tones as well. And I think that's an issue that needs to be explored. But overall, I still think at 97% specificity, 93% sensitivity is pretty good for these devices. So these were the 2 large population studies that tested wearables in the general population. They both recruited patients who were 22 years and older. And so, of course, the prevalence of AFib in the younger population is not as much. I'll start with the Apple Watch study. It was published in 2019. It was a prospective single group pragmatic study. It used the Apple Watch, which had a PPG device, just like Giorgio described, but it's now tied to an algorithm. And I want to point out that that algorithm is actually the main advantage or the main selling point for some of these devices, is the ability for these algorithms to distinguish AFib from regular rhythm or from other arrhythmias. So basically what happened in this study is that patients who had the watch, they paired the watch with an app. There was some sort of continuous monitoring from the watch, and when it detected a certain number of tachograms that seemed to be like AFib, it will send a signal out to the patient to get a telehealth visit. And when they get a telehealth visit, they'll be given an ECG patch. And when they get the ECG patch, they'll have to wear it for 7 days and then return it. Of course, you can see in all those steps, people will probably not get to do that. And that's kind of what happened during the trial. So about 2,000 patients out of the 400,000 that studied in the study actually got an irregular pulse notification, and then 450 of them returned the ECG patch. And the ECG patch was worn for about a week, usually about 2 weeks after, on average, after they returned, after they got the notification. And so what did they find in this study? They found that about, we said about 300 of them, or 350 of them got those notifications. 153 of them actually had AFib that was detected during the study. And how we calculate the positive predictive value here is because, AFib is, paroxysmal a lot of times. And so in that 1 week period, they probably wouldn't get an episode of AFib because they only monitored for a week with the ECG patch. But whenever you had an ECG together with the pulse notification that signified AFib, that happened together or coincided about 84% of the time. So that's why we think the positive predictive value is about 84%, which is, not perfect, but desirable in terms of detecting AFib. So pretty good specificity, I would say. And then for those above age 65, where the amount of AFib is not larger, the positive predictive value was still a reasonable 78%. And this is just showing some of that, a graph with that. I think another thing that was very interesting in the study is that for those ECGs that didn't show AFib, that got a notification, but it wasn't AFib on the patch, you could see that a good number were PACs, PVCs, and atrial tachycardia. And now the Fitbit study was published 3 years later. This was done by Dr. Steve Lubitz from Boston. And it was also another prospective single-arm remote study. Now, they also used the PPG device, which is the Fitbit. But this time, they also had the advantage of having an accelerometer and a much better algorithm. And again, I think the algorithm and the AI piece in this for wearables is actually it's something that is very, very interesting because that's kind of what improves the effectiveness of these devices to detect and tell you that this is AFib and not just a random arrhythmia. So again, it was very similar to the Apple study. Patients had to, use the Fitbit. They get a pulse notification, and then they have to go get a telehealth visit and get an EKG patch. About 450,000 patients participated in the study. About 1,000 of them had that, about 4,000 had the notification, and 1,000 of them ended up getting the patch. And again, the yield here was about 32%. So we always have a drop-off between patients who actually get the notification and who wear the patch. But whenever they wear the patch and they have a notification, the positive predictive value was, again, 98.2%, which is really impressive and way better than what they had in the Apple Watch study. And when you look a little bit into the weeds as to why they got much better accuracy, it was because they had the accelerometer. So basically, if the patients were moving around or, exercising, it wasn't going to ignore, it will ignore those notifications or it will ignore those tachograms. And so most of the recordings were kind of when the patient was still or at night. And so, I feel like it's a bit more accurate in terms of how it detects it. So in terms of, the devices themselves detecting AFib, I do think they detect AFib. And again, we have a lot of other studies that have shown that compared to the population that wasn't screened with a wearable, the wearables will detect more AFib, usually about 3 to 4-fold on average. And so the fact that they're picking up AFib, I think is a very important plus. And so these are some of the studies that we'll be discussing later on in the talk. And I just decided to summarize it here. We'll go into some of them in detail. But before we go into some of these other studies, I just wanted to also say that one other important factor that was picked up in some of the studies is that not only does it detect AFib, but it can tell you how much AFib you have. And if you remember at the beginning when we were introducing this topic, the burden of AFib, I think, is the critical part of subclinical AFib. And if these devices are reliable in quantifying burden of AFib, I think that's where they're going to be very useful. And I actually came across a good number of studies that showed that they were important in determining burden, but this is just one of those ones that showed that very good correlation of the PPG and an algorithm with AFib on a patch. And so we come to the big question. So the fact that you can pick up AFib, does it necessarily mean that you're going to improve patient outcomes? And sometimes in medicine, that's not it's not a straight line. And that's why it has to be tested in a clinical trial. Now, unfortunately, in this space, because these devices are new, we don't really have a lot of outcome studies that specifically look at the question of screening and whether you're going to have an impact on stroke and mortality outcomes. We've done a lot of extrapolation from studies that use the implantable devices or devices that can detect atrial high rate episodes. But one thing I would say is that when we look at some of these studies, and these are just a few of the studies that have been done in this space with outcome measures, what we find is that stroke reduction has to be balanced against the bleeding risk. Artesia is the latest study that just came out that showed substantial benefit in stroke, and it was statistically significant. The other studies have, when you look just at stroke, not been significant. But again, they are smaller studies. It's really hard to get them powered to detect it when you're looking at these outcomes. The bleeding risk, however, is quite substantial. However, someone can also argue that, bleeding risk is relative. A stroke is quite devastating. And like I mentioned earlier, patients would prefer to actually die than have a stroke sometimes. You wouldn't say the same about bleeding usually. And so that's another thing. One thing I don't have on the slides here, but has been consistent in all the studies, is that the incidence of subarachnoid bleed, which is the most critical type of bleeding, was the same in both groups, but very small numbers. We're talking about 4 events on both arms in some of these studies. And the meta-analysis of these RCTs, like I alluded to, also has shown that there's statistically significant benefit. Again, the number needed to treat in some of these meta-analysis is very small, but in terms of whether there is an impact on outcomes, I think it's just an issue of powering the studies. And actually, more studies are going to be coming. So I'm going to quickly just describe one of these studies that was done as an outcome study. And Stroke Stop, I think it's probably the largest study that has looked at screening for AFib and outcomes. It was done in Sweden. It was done in a population-based way. They invited everyone between 75 and 76 in certain districts of Göttingen, and they randomized them to getting invited to get screened or not getting invited to get screened. Now, unfortunately, only half of the people who got invited to get screened actually came in to get screened. And they did an intention to treat analysis, so they had to put everybody in the same bucket. And I think that's one of the reasons why we'll see what the results look like. But the primary outcome was stroke, systemic embolism, and bleeding with hospitalization, as well as mortality. And they followed the patients for about 7 years. And this is what they found. So in terms of when you do that intention to treat analysis, where you're just strictly going by how patients were randomized, the primary outcome, which is a combined outcome of stroke, systemic embolism, some bleeding, and mortality, showed a benefit. There was a 4% reduction that was statistically significant. The NNT, or the number needed to treat, was 91 over 7 years. In terms of stroke itself, it didn't meet significance. But then when you actually separate it into those who actually got the screening and those who didn't get the screening, you can see that there's a clear 24% reduction. I know that analysis is not, it's not what we should be doing, but, it just shows you that there is some benefit in detecting AFib a bit earlier and doing something about it. And another thing I found when I was going through the literature was that there are people who are really enthusiastic about this. So there's this consortia called the AF Screen and the EU Screen, the AF Screen and the EU Affect Consortia. And they're in about 37 different countries, and they're all trying to come together to, collect data that would help, help us in this space to get more data, outcomes data, pragmatic trials that can help. And so more data is actually coming. And you can see a list of trials that we're expecting in the next 5 to 10 years, or well, 3 to 10 years. I think Heartline, which is the study using another Apple Watch device, as well as an algorithm from J&J, is going to be very interesting. It's hoping we're going to get results in 2025. And then the Safer UK study has about 100,000 participants. It's also a huge population-based study that we're hoping to get some data on. And next thing I'll talk about is the fact that wearables are cost effective. And so there's several studies in the literature. I just picked about 3 of them. The very first one was Stroke Stop, which was a really well-organized study. And it actually showed that it was cost saving. And so it saved about almost 2 million euros. It increased QALYs by about 65 for that population. And after 3 years alone, you could get cost savings because of the stroke reduction, as well as the other effects you get in that population. And then other studies have shown different estimates of cost effectiveness. Another thing I want to point out is that there are other benefits of wearables. There's a benefit in patient education, the fact that patients become more conscious about their health. Then there's this issue of evaluating progression of AFib. So a lot of subclinical AFib actually will progress with time. This is just a graph that just showed one of, a sum of the data of progression in 3 trials. And you just see that, the amount of AFib you will detect in that population actually grows with time. Also, if patients know about AFib, even when you don't want to anticoagulate them, you can start having them on measures that can help them prevent AFib in the future. For example, weight loss, physical activity, decreasing alcohol intake, and treating obstructive sleep apnea. And another thing about detecting patients with AFib early is that they potentially could get rhythm control, which in trials like East AF4 and early AF we've seen that they have outcomes benefits. Another thing that's also very interesting, I think about when I think about the wearables, is that they can also change our paradigm around how we actually treat atrial fibrillation. And so we've heard of the pill in the pocket approach to treating sort of proximal atrial fibrillation in terms of the heart rate. There's also a potential to have a pill in the pocket anticoagulation. Now, this is still going to be tested in this clinical trial that's being run by Rod Passman out of Northwestern, but it's actually built on pretty good data. So there are 2 trials, React.com and Tactic AF, that have shown that you can reduce the amount of anticoagulation that you are giving to patients if you can anticoagulate them only in that AFib episode period, especially for patients who have very infrequent episodes of AFib. In React.com, they got a 94% reduction in anticoagulation use. In Tactic AF, they got a 75% reduction in anticoagulation use in that population. And they followed these patients for about 112 patient years, and they've not had a single episode of stroke. And I think based on that data, that's how Rod Passman was able to get this funded by the NIH, I think to the tune of $37 million, to study this potential strategy where they will basically have patients with an Apple Watch and then monitors them for AFib. And whenever they get AFib, they'll get that notification to take their blood anticoagulant. They take it for about a month, and then they stop. And then we'll see whether there's an outcomes difference. So I think this is also a very important aspect of wearables that we're going to test in the clinical trial and see if this paradigm works. And then just before I round up, I just want to say also that wearables are safe. The Apple Heart study had like almost 500,000 people in. The Fitbit study had similar population in. And you didn't really see any really serious adverse effect. And, the issue of anxiety is something that people talk about sometimes with AFib, and we didn't see that much in those 2 studies. REHAS-AF is another study that randomized 500 patients each to a life core cardio routine care, and they found that patients were pretty much satisfied and didn't really have a lot of psychological issues with it. And the last point I want to make just before I summarize is that the guidelines now recognize wearables. So we had the new atrial fibrillation guidelines come out late last year, and they did have a note saying that particularly for detecting burden, wearables are going to be very, very helpful. So I'd like to summarize very quickly and say that, I think wearables reliably detect atrial fibrillation. They probably improve stroke mortality and outcomes. At least we have statistical significance in some of those studies. They are cost effective. They could help us with risk factor modification and early detection. They can reliably quantify the burden of AFib, and they might in the future shift paradigms on how we treat atrial fibrillation. The new guidelines also recognize the utility of wearables. I think the challenge that remains now is how we can target the right population that will benefit the most to correctly use this data. And I'm going to transition now to Giorgio to continue.
All right, thanks, Kenny. So for my side of the argument, I hope that at least I can convince you that we should at least be cautious about using consumer wearables for screening of AFib. So Ken already talked about the WHO criteria of what makes for a good screening tool for any given disease. I'm not going to go through all of them, but I just want to make the argument that with consumer wearables, although we can all agree that AFib is an important problem, regardless of what tools you use, and it can be recognized in a latent or early stage, it doesn't quite meet many of the criteria outlined by the WHO here. Whereas opportunistic screening, which is the only way of screening that is really a class 1 recommendation in the guidelines, meets most of these criteria. So what are the key questions when thinking about consumer wearables in screening of AFib? First is the question of accuracy. Can we trust the readout from these wearables? Secondly, is the outcomes. Is the information that comes from these wearables actionable? Can we improve outcomes with that information? And then there's other miscellaneous considerations about cost effectiveness, as Kenneth was talking about, and other things like medical, legal, and ethical implications of the use of wearables. So first, let's start with accuracy. We are all familiar with computer algorithms that can detect AFib on a 12-lead ECG. And those algorithms are actually very accurate. But the same does not apply to wearables. There's several studies that have pointed out that only a very small proportion of all of the data collected by these devices is analyzable, including the Fitbit heart study. And this is mostly due to motion artifact and other issues. And also, of course, as everybody knows, since PPG can only detect a regular heart rhythm, an irregular pulse per se does not necessarily mean AFib. As Kenna mentioned, there's 2 very large studies that looked at this, about the question of accuracy of these devices in detecting AFib, the Fitbit and Apple Heart studies. And for those 2 particularly, I'm going to offer my counterpoints. So just to recapitulate a bit, Kenna already talked about the trial, but out of the 500,000 people that were enrolled in this trial, only 1% had an irregular pulse notification by PPG. All of these patients received a 7-day ECG patch in the mail. Unfortunately, as Kenna alluded to, only 22% of these patients returned the patch, so that was analyzed. And 32% of the people that returned the patch had AFib on the ECG patch. So I want to focus the attention on the positive predictive value, because I think an understanding of how it's calculated is really important. Does the positive predictive value based on this is 32%? Some people, maybe rightfully so, may say that this is unfair because you could have a notification from the watch upstream for a very short episode of AFib and then never have it again by the time that you have the ECG patch on you. But the authors reported a positive predictive value of 98.2%. But where does that number actually come from? It comes from this hyper-selected population of patients that had a new irregular pulse notification while wearing the patch. And 221 of these patients had concurrent AFib with this notification. So we have to keep in mind that positive predictive value is highly affected by disease prevalence. And what is the disease prevalence in this subpopulation? 98.2% by definition. And so you can see where I'm going with this. So if we take a theoretical test example that performs poorly intrinsically with a sensitivity and specificity of 50%, and we test it in a high prevalence population of the disease of interest, the positive predictive value will still be 90%. For the Apple Heart study, similar thing. It was designed very similarly. 21% of the people that had the notification returned the patch. 34% of these patients actually had the AFib on the patch. And the positive predictive value was calculated off of this subpopulation here with high prevalence of AFib. So many of these newer devices, though, the new generation is actually ECG capable. This is really interesting because it can actually help close the gap of accuracy. As you know, as everybody would agree, you know, if you have an irregular pulse notification, you still need to confirm AFib with an ECG. And these devices allow you to do that. All you need to do is to have both upper limbs in contact with the watch, and you essentially end up with a lead one, which may not be the best aligned to detect, you know, AFib, P waves, and analyze P wave morphology. But still, it's really nice to have a way to really follow up on that notification with an ECG. And the basal wearable study looked at the accuracy of these devices. So this was not about screening. This was already a relatively small amount of patients that had a high pretest probability of AFib. And in fact, 81% of these already had known AFib. Basically what they did is they had each patient undergo a 12-lead ECG and then a 1-lead ECG back-to-back with all of these devices. And when they had the 1-lead ECG analyzed by an artificial intelligence algorithm, you can see that the positive predictive value was pretty poor. And this was due to a lot of the tracings classified as inconclusive by AI. When the same tracings were read by a cardiologist, then the positive predictive value increased dramatically, emphasizing that even with these newer devices, we still need physician supervision. So in terms of outcomes, I just want to focus on these 4 trials. Stroke Stop, Ken already talked about, so I'm just going to offer my counterpoints. Essentially here, I divided them into 2, because the one colored in red, the Stroke Stop and Loop trials, are really about screening per se. The newer trials, NOAA AF-NET6 and Artesia, that just came out last fall, they're really about treating subclinical AFib of at least 6 minutes and with anticoagulation or placebo or aspirin, and see if that affects outcomes. So for Stroke Stop, again, I just want to draw your attention to their primary outcome, which was a composite outcome. The 2 curves overlap quite substantially. The difference that they observed is really, really small. So you can make the argument that it's not clinically significant, and it barely reached statistical significance. When looking at ischemic stroke only, the trend becomes a little stronger, but it doesn't make statistical significant. Of course, this was an intention to screen analysis, and Ken already talked about that a lot of patients dropped out of the screening, and that may affect the result. So to offer more evidence to suggest that these 2 groups on the Stroke Stop study were not all that different in terms of outcomes is the fact that the authors did observe that more AFib was diagnosed in the patients invited for screening than the patients in the usual care group. However, oral anticoagulation did not significantly differ in use over the years between the 2 groups. So it's really hard to think that the 2 groups will have different outcomes if they essentially receive the same treatment. What about Artesia and NOAA AF-NET6? So both of these studies are quite similar. They both look at patients that are older, they have a high CHA2DS2-VASc score, they all have implanted cardiac devices, mostly defibrillators and pacemakers, and they at least had a 6-minute episode of AFib on the device. In Artesia, they couldn't go over 24 hours in terms of the episode to be included. But you can already see that, you know, we're extrapolating this data to apply it to consumer wearables. But of course, this is a very different population that is much at higher risk than your average wearable user. So these patients were randomized in Artesia to receive apixaban or aspirin, in AF-NET6 to receive edoxaban or placebo, keeping in mind that half of the patients in the placebo group were actually on aspirin. And in terms of outcomes, Artesia, as Ken mentioned, it was a positive trial with number needed to treat in the 200s, whereas NOAA AF-NET6 was a negative trial. There was no statistically significant difference. In terms of bleeding, though, both of the trials found statistically significant more major bleeding and in FNS6 death or major bleeding in the group receiving edoxaban. And since most of the patients in both trials were on aspirin in the control group, this actually is expected to be underestimated if you compare it, let's say, to true placebo. What about the loop trial? In my opinion, the loop trial is probably the best one to extrapolate and apply to wearables, because in a way, an implanted loop recorder is really probably the best wearable that you can have in terms of accuracy. This study was conducted in Denmark. These patients were also older, high CHA2DS2-VASc, so higher risk. They were randomized to undergo ILR implantation or usual care. As expected, more AFib was diagnosed in the ILR group rather than usual care, and more anticoagulation was started in the ILR group as opposed to the usual care. But interestingly, both for primary and secondary outcomes, the authors did not observe any statistically significant difference in any of the outcomes, even in their subgroup analyses. Major bleeding had a trend of more bleeding in the ILR group, but there was no statistical significance there. What are other considerations to make about the use of wearables other than outcomes? So first is the legitimate expectation of privacy for patients of health data. So there's a question of who can access the data. So there's a high potential for data misuse. Who owns the data? Generally the company that makes the wearable rather than the consumer patient. And who is in charge of making sure that this data is stored securely? Secondly, we have to remind ourselves that most of these health apps are not registered as medical devices by the FDA. There's also, as Ken mentioned, a potential for even more inaccurate PPG measurements on darker skin tones, potentially creating issues there. And also, there's an issue of access for all of the patients that potentially cannot afford consumer wearables. What about cost effectiveness? Kenny already talked about the stroke stop analyses that do suggest that screening for AFib may be cost effective. However, we have to keep in mind that all of these analyses, we're looking at trials that looked at strategies of screening that were physician initiated in a high risk population. And that is not necessarily applicable to wearable users. And because of this, it doesn't take into consideration the high false positive rates that PPG devices can have and the large amount of data that the healthcare system would have to deal with that can add burden and costs. So in summary, should wearables be used for screening for AFib, at least from my standpoint? On a general population-based level, most likely not, as it includes a lot of patients that are low risk for both AFib and stroke in general. In a highly selected, high-risk population, probably yes, but there's still a lot of work to do, both in improving the algorithms to detect AFib with these devices, improving the devices themselves, perhaps. The screening, in my opinion, should always be physician-initiated, and thirdly, screening protocols should be designed and validated first. And then, it probably, and again, I also alluded to this, the fundamental question about the AFib still remains. Like, how much AFib burden is actually clinically significant? How much AFib is enough AFib for each individual patient to prompt us to anticoagulate and improve outcomes? So with that, we're just gonna make some closing remarks and hopefully meet in the middle. So I'm gonna hand it over to Kenneth.
Thank you so much, Giorgio. So I'll just go through the guidelines on this topic and then also just have one small remark at the end. So this is the new ACC/AHA guideline on duration. And I think if you're not familiar with it, I think it's a very interesting new update. So basically, if you detect AFib on some sort of device, usually a wearable or CID, they're saying that if it's between 5 minutes and 24 hours, they have to be a CHA2DS2-VASc of at least 3 to initiate anticoagulation. And then if it's more than 24 hours, our usual threshold of CHA2DS2-VASc of 2 or more is still what we use. And that, to me, is one of those big changes that has come about because we have these devices. Also, I put this slide up previously, but they did say that these devices are going to be useful for helping us with burden when we have them available. I'll still also point that the USPSTF, the President's Task Force, Preventive Services Task Force, still thinks as at 2022 that we need more data for the use of these devices. And then I also wanted to talk about the European guidelines, which call more for opportunistic screening, which is patients who come to a primary care office should at least get an ECG, make sure they're not in AFib. I also want to point out that the European guidelines, this same European guidelines 2020, recommend treating a child's VASC above 2 or more for AFib lasting more than 5.5 hours. But that's a little bit outdated given that we now have data from Loop, Artesia, and NOAA 6. And so this is my last slide. And what I have learned by looking into this topic is that one, AFib is not a binary variable, and the risk and burden are the two sort of competing variables in our mind that decide on what we should be treating. The idea is that even if we don't treat, we can address risk factors and we can prevent AFib in the future. But one thing that's very interesting too is that, and that's why I like that seesaw at the bottom of the screen, is that if you get a device that is perfect, that can detect all the AFib, the problem with that kind of a device is that you start detecting AFib that doesn't probably need to be acted on. And so you don't really need, you don't really need the most perfect device. You just need a device that maybe in a population has been screened and shown to detect AFib that can be acted upon. Yeah.
All right, so we want to close the talk with like a practical algorithm. So we talked about screening a lot, but still, we still need to deal with the patient that comes into the office and tells us, I'm worried that I may have AFib. My watch is telling me that I have an irregular pulse. So what do we do with that? There's still not a lot of guidance in terms of evidence. But we thought that this algorithm could be like a reasonable approach. So starting with devices that do not have ECG capabilities, if we do get, if represented with a irregular pulse detected by a wearable, we should definitely confirm that with a medical grade cardiac monitor. If then that's positive, we see AFib in that, then AFib is ruled in and that's it. If it's negative, then if our clinical suspicion is still high, we could opt for more monitoring, like with a higher duration. And if we see AFib there, we would rule it in. If the pretest probability is low, we could just stop there and consider AFib ruled out. What if we have the ECG capable wearable? In that case, I think it's important for the physician to actually review the tracing. If it's very convincingly positive, it may be reasonable to start an oral anticoagulant upfront, depending on stroke risk, and maybe at the same time confirm the diagnosis with a medical grade cardiac monitor. If in doubt, of course, we should always use the cardiac monitor in the office. And then if it's convincingly negative and the pretest probability is low, then we can consider AFib ruled out on the basis of this tracing. So and with that, we wanted to really wholeheartedly thank our mentors, Dr. Lampert, Dr. Rosenfeld. They gave us incredible feedback. They spent a lot of time, did a lot of work. So we really, really, really appreciate them, and also for being here today in such a snowy day. And we wanted to thank you all for your attention and invite any questions. We first are going to have our mentors kind of make a couple comments and then open up the discussion to the rest of the audience. Thank you.
Well, that was a super discussion, both the pros and the cons. I think you guys both did a great job to help work to create this watch. I would say for me, maybe because I was working with Giorgio, but for me, I have two main ways that I've just emphasized that Giorgio brought out, that I've just emphasized again. First of all, is that we don't yet know what to treat. And I think we will. I think, between the two studies that we've heard from both the fellows, Artesia and NOAA AFNet, were sort of, one was negative, one was borderline positive. They both have very short durations of AFib. And so I think the EP community is really looking forward to some of the sub-analyses where we'll really know better. There's a lot of difference between 5 minutes and 24 hours. So we're in that. I think we may get the answer, but I don't think we have yet. And then the second point that I would emphasize was what Giorgio said at the very end, which is that what we're going to do with all that data. So even if we knew what to do with either person, you know, you have your 6 hours or it turns out 2 or whatever, I mean, we're going to treat them. But as a strategy, like actually making that strategy work is mind-boggling. Because we know just from the remote monitoring of pacemakers and defibrillators that the amount of our, even in very defined population, we've got like full of MAs to RNs to APPs, like dealing with incoming data from online. It's expensive, it's work intensive, it's a ton of work. And so thinking about, you know, the fire hose that is going to come out of it, if we actually start screening in any sort of systematic way, like I think we would need to have some processes in place in order to make it work. Who's going to interpret that? You know, how are we going to talk to the patient? How's that whole thing going to work? So I think, you know, I think it's possible in the future, but I think we've got 2 big steps to figure out first.
But you would need that army of techniques, so
I mean, so far, I think we're a long way from
Yeah.
complete absence of additional. You know, I think, you know, a person figures out ways.
understood.
Yeah.
But that technology should be at some point.
It's almost like that. Yeah,
So
we
it's
are.
like that.
So I just want to say, second what Rachel said, I think you guys did a really wonderful job. And I think we're at a precipice, you know, I think we're going to have more information soon that's going to make this more valuable. I think a very important thing is recognizing what the duration of that is that you can get benefit from treatment. And that'll reduce the risks because you'll be treating less people and people will be treating less time, which will increase the relative benefit. I think we focus on stroke because that's the most dramatic outcome. But as Kenny said, I think there are a lot of other benefits in the present climate. We undertreat atrial fibrillation. And 20 to 30% of people with subclinical AF are going to go on to have clinical AF. And if we watch them more carefully, hopefully we won't miss some of those people. Also, we can do things in the interim to make that a less likely. And we've learned that rhythm control or not is increasingly important in taking care of patients. That'll certainly be facilitated.
Thank you.
Comment, great job summarizing, you know, a complex field. I think it'd be rapidly evolving. I think I want to highlight that last point, which is, you know, the challenge of using these devices to enhance the interactivity of the information. So, you know, I think the strategy that need to be evaluated are whether this kind of says, you know, okay, sit down. We highlight something. Your phone can tell you to sit down and do maybe a more comprehensive, you know, longer screen. You know, there's all that kind of those features that haven't been tested. The other comment I would, 2 more comments. One is, you know, most of you highlighted the importance of the black box AI that, you know, underlies a lot of this work. And I think, you know, as those algorithms and understanding of how to integrate that AI into these worlds, I think we'll have to retest and reevaluate these. It's not like we did the Apple Watch study. And I think each iteration will have different kind of sensitivity and specificity. And maybe the last comment, which is a methodological one, I mean, I'm very happy to see you each highlight the challenges of how they got to the PPVs, right? You know, I'm not sure I think there's probably a very big difference between those individuals who are told they have something and choose to wear a device and return it, than those who are told never give advice and never return. And I don't know which direction that goes, right? And so I think you have to be very cautious in the interpretation of these statistical parameters with this kind of work until you have a larger sample of the population who's who you get the confirmatory assessment, and that's a challenge. It's pragmatic at one end, but it has its challenges. So I think you've given us a good framework for how to follow this literature as we go, which is certainly will to progression.
Thank you. Thank you.
Excellent discussion. And one thing I want to make a comment is that atrial fibrillation is not atrial fibrillation. So many patients, some patients actually have atrial fibrillation as the first manifestation of cardiomyopathy in future. Many other diseases that are associated with atrial fibrillation initially. And some mechanical arrhythmias start with atrial fibrillation, or some arrhythmias are associated with atrial fibrillation. So I think that device may be actually going to be very particularly well for the specific group of population. Now I have a question, and that is, when you presented the Fitbit, you said cognitive predictive value independent of the age, which was the strangest finding, because as you know, test probability is so important, and people at age 65 and 80, they should have actually better. And so that I realized that actually this is because of the definition they use for how actually you have to, but was 98% for all ages. So I was wondering if you look at the patients that are older and they were detected by also EKG, how many percent of older they were?
Yeah, so
It's actually independent of age, right?
yeah.
It was similar across age.
Yeah. So in the Fitbit study, they actually broke it down by age, but they only used one binary age classification. So they below 65 and above 65. So we don't have that kind of breakdown that they had in the Apple Watch study. But still, for those above 65, it seems like because it was still pretty rare, the positive predictive value was kind of similar. So it wasn't statistically significant. I can't remember the exact p-value they got when they ran the interaction term for that, but it wasn't significant. Again, I agree with you that it's going to change slightly. In the Apple study, it only went down a little bit from 84% to 78%. But I totally understand that that's something that you probably will get when you have in a population that has more AFib. Yeah, sorry.
So, terrific discussion. Thank you for going through all that. I think this is the first fellows debate where you try to find a common ground. I don't remember one. But, I think what Linda and Rachel both said about we need to understand how much AF is, poses a risk and needs to be treated is such an important point. And you both made that point too. We don't really know that. I wanted to just mention something that we used to always say AF because AF. Right? That was always something. And I don't know if electrophysiology world still feels that way, but if you had some AF, you were more likely to have one. It may be that 5 minutes of AF every 2 days, that there's some gene expression program that gets triggered, and it accumulates in your structural remodeling potential that leads to sort of persistent inflammation. So I guess I'm making points, not really a question. There's so much work. I think there's a good potential where this.
Thank you.
That's still something.
That's one of the reasons why early, we're treating it early.
Yeah.
And that's, like the original evidence study showed that early treatment valid. So I think that is definitely. And this is what it's used.
So, 2 quick points here also. So being at Yale, having access to the excellent databases that we have, why not get EKGs? See patients who are at disability based on the EKGs that have some sort of test, whatever the threshold is, have the variables and see what happens.
Yeah.
So it would be a very nice easy practical project. So you're essentially identifying the patient they're going to allow for at risk for the fit, then use therefore to diagnose. We're going to do this still. One thing that I was puzzled was the sensitivity information. How do you get the sensitivity? That 90%.
Yeah, so I think that, they always compare it to something that I guess they define as the gold standard. Most commonly, it's a patch. Other times, it's a 12-lead ECG. But of course, by nature of the fact that the two tests should be run at the same time, that's really where the challenge is. It's because an episode can be very fleeting. And so in order to have a really great assessment for the accuracy of these devices, you really should have these two together. And that's where the Heartline study will really help, because it's the first study, to my knowledge, correct me if I'm wrong, Ken, that looks at ECG capable devices that have both the PPG, that is almost like a first line of screening for an irregular pulse, and you can confirm that almost in real time. The problem with it, though, that I was thinking about, and I don't know if you know more than I do, is that, again, it still requires the user to put their hand on the watch. And a lot of the PPG signal is disturbed by movement. So a lot of the PPG data that is usable is at night. So probably a lot of these notifications will occur at night.
And we can't confirm. Yeah, I think that's the big challenge. There is no telemetry device that is a wearable yet, except you get a loop recorder.
Yeah.
There is no telemetry. You always have to touch the device in some way, and that will distort the PPG signal.
Yeah.
But
Great points.
yeah.
You got a study of a stroke patient without initial presentation of fibrillation and with the Fitbit or something like that to see how many percent of them.
ILR.
Stroke.
Yeah.
Yeah.
Yeah, but
But this highlight, I mean, Eric Bader who's developed a very nice stroke process in clinic that many people here are involved in. It would be something that's quite interesting is to even look at opportunistically those individuals who are willing to wear their Apple Watch or Fitbit who are already being implanted for cardiac stroke for their monitoring part of that program and see what you get. It's a good starting place.
yeah,
Yeah.
for sure.
We have, for example, in our clinic, a lot of patients with the destiny, right? And family members come with the atrial fibrillation without any cardiomyopathy. There's certain genetic disorders that present initially before cardiomyopathy. And that would be something that look at the database.
For certain.
Make one comment here. I think this is, wonderful. You guys did a great job. But it's also kind of goes in, we love these wearables and we get a very precise measurement of how long they've been in AFib. Whether 17.3 minutes is the time frame. We all know that the biggest risk in AFib is the underlying risk factor. The guidelines kind of say that, okay, if it's between 5 and 24, you have to have 3 risk factors. If it's more than 24, you only have to have 2. But we all know that the CHAS-VAS, it's the best we have, but it's not very good. What I really hope is this with AI and how much of the clinical data hooked into this to really give a patient's risk. I think the duration is going to be really a small component of the overall.
Ultimately, they're focused on sort of score, right? Real plug in information and that's put all of that together.
Right, but hopefully we can even get something better with CHAS-VAS. Great data.
Was that a big capacity out? Thanks so much, everyone.
Thank you. Thank you.
Yeah. Everyone be careful driving.
Perfect lane.
My question is, what's the best wearable?
I don't know where you would put it. I mean, I guess things would be okay wearing a size patch.
So are there